here in just a moment.
Also,
Right.
I have a
Here we
small.
go. Oh. And recording has started, and we're letting people in from the waiting room, so people will be able to join here in just a few moments. Just as a reminder to everyone, this is the meeting for the Equity, Access, and Cultural Considerations Committee. The meeting is being recorded. My name is Dominic Zerlo with the Department of Health, and we are here with the chair, DezBaa. And with that, since we are on time and moving forward, I'll go ahead and turn it on over to you, DezBaa. So thank you.
Hello, thank you, Dominic and DOH admins. Really appreciate your time. So for today, we just kind of wanted to go over a couple of things. From the last meeting, we did have it announced that we did get the $630,000 appropriated money signed in from Governor Michelle Lujan Grisham, and that is that's been signed in. It is going to go into effect this July for the fiscal year, I believe. And it does, I wrote the notes on this. There's a specific term that I now have forgotten what it is, but the money won't go away. The money will just stay there until it is, until it runs out. And not only that, but it also cannot be like recharged, so that it's not going to come back. So any other money that we are going to be looking towards anything has to be earmarked again. But those are good things in the sense that even though it's going to be going into effect in July for the fiscal year, for 2027, it will the funds will be there, and it's not gonna revert back into, it's not gonna get reabsorbed back into any other. It's not gonna get reabsorbed. So that's
DezBaa, sorry to interrupt. It's non-reverting is the term you were
non-reverting.
looking for.
Yes.
Yeah, but it's hard to remember. I always have to look it up too. So.
Yeah, I had it in my notes, and then I realized that these are not notes that I wrote down, the ones that I picked up. So in any case, that's good. But with that, that means that we have to figure out now how that money is going to be distributed to the various patients that will be seeking medical psilocybin for treatment in the coming year. So with that, we're looking into potentially, is that going to go, like, how is it going to be allocated? How is it going to be distributed? Is it going to be based completely on income only, where the national poverty rate threshold is currently at 15,960, I believe. I had it up here again too, and then I lost it. Yes, $15,960 for one individual. Two people is $21,640. Three people, $27,320. And even though those are the federal poverty guidelines, we all know that $15,000 isn't anything. Not even someone who needs the money can subsist on $15,000 anymore. That's just absurd. But what we're trying to look at, though, is what kind of coverage a person would need based on those metrics. And if we're actually looking at that, are we looking at rural areas? Is it going to be based on demographic, like geography, and how that's going to look? So, this is where we definitely need outside input from everybody to kind of just say how we're going to allocate this money. And that's specifically with the equity fund. We're currently now trying to figure out, just to kind of touch base a little bit with what happened in the last board meeting. So this is a committee meeting. So the board meeting is that we're going to start looking at the training. What are the requirements for licensure and facilitators, what that looks like, grandfathering in out of state certifications, what kind of practicums, etc. So definitely look for the training committee meeting that is going to be happening, I believe, in April. But that's the next thing that we're going to be trying to item on the agenda for the board is what that's going to look like. In the meantime, trying to make sure that we have something to recommend to the board, to the Department of Health. It's going to go through two things. Committee recommends to the board, board then recommends to the DOH. What it's going to look like for the year 2027. So we definitely need a lot of input in that. And then for those who are concerned about Native federally recognized tribes input, we are trying to get in the process of getting meetings with tribal liaisons from the Department of Health, getting that set up, getting some invites with the governors from the different pueblos. We're also looking into having an in-person committee meeting in the future in Santa Fe. So we need to set that up as well. So if there's anybody of the participants who have kind of an idea of what necessarily we should look at so that we can recommend it to the board, how we're going to look at allocating the money. What does that look like? Are we covering like 100% of a treatment? Are we covering 50%? What is the breakdown and the threshold? So we can go ahead and try Hannah Rose.
Awesome. Let's see. Hannah, I have enabled your mic. You can speak when ready. And just as a reminder, the mic icon should be up at the top right part of the banner on Teams.
Thank you. I've done this so many times, and then, you know, the mic just, thanks.
No worries. It's elusive.
I know. I was like, where? I've already done this. Okay. Hi. My name is Hannah Rose, BSW student, first generation Curandera. I'm really glad to be having this discussion, supporting you all in this from a social work and like, you know, Curandera perspective who's not from tribal land, but cares about, yeah, how are we going to use these resources? One thing that came to mind, DezBaa, is that how I say your name? DezBaa?
DezBaa.
Yeah. DezBaa, sorry. I didn't have the word written out, your name written out. DezBaa, when you were speaking, and wondering about paying 100% or not, what came to mind is the importance of investing in our health. And even if it's just a small monetary amount, the fact that low income populations will value their money more preciously and maybe be in a lack mentality. I've witnessed some magic happen around people that then invest in their health through whatever budget they can. So I guess I just want to name that and take that into consideration because it trains our culture to budget, right? It trains our culture to consider that this investment is no, I don't want to say no different, but it can normalize that like, oh, you're willing to, if the person's willing to go to a pharmacy and pay the copay for, you know, the antidepressant, then let's normalize being willing to come into this program and pay a copay to normalize that investment of health. And I feel complete in that share for now. Thank you.
Thank you.
All right. Thanks, Hannah. And next we've got Denali Wilson. Denali, I've enabled your mic. You can speak when ready.
Hi, everyone. I have a couple of thoughts. My name is Denali Wilson. I'm the Director of Strategic Support for Healing Advocacy Fund in New Mexico, based in Las Cruces. And so I think we have to think about the equity fund in conversation with the work that's being done to make sure that treatment is covered by Medicaid and by private insurance. Like that has to be a part of our vision for equity and access. And I think the two work hand in hand. So there's a couple of possibilities. One possibility is that when the program is up and running on the December timeline, maybe we are not in a place with the state Medicaid office, the healthcare authority, that there is coverage. My hope is that we are. If we're not, then I think we have a conversation about covering 100% of treatment. But I think, $630,000 for a whole treatment for someone, which can range upwards of $3,000 for all the costs, right? That's not nothing, but it certainly doesn't go as far as us paying for what I would recommend is thinking about paying for the one, until there's FDA approval, they're not ever going to be covered part of the care, which is the administration and the medicine itself. That's a lot of time for providers that they're not going to be able to bill to Medicaid or other private insurance. And so if we think about the equity fund as a gap cover for that part of the care model that can't be covered by insurance at the moment, like in the current state of the law and the FDA, I think that provides us with the ability to provide care to so many more people. I think too, there are some in other subcommittees, the end of life care subcommittee, there is consideration of including, and I'm really excited about the conversation to include in care and in eligibility for care family members who are caretakers for those directly receiving palliative care. And I think that is a real opportunity for some transformational healing at end of life. And I'm really excited about that. And have the question of how that fits within equity and access. I think within a medically integrated model, there's going to be more question as to eligibility. If you aren't receiving palliative care, but you are a caretaker, I'm using that as an example of potential populations where the equity fund maybe is needed to cover individuals who are eligible to participate within the program that we've designed, but can't that their care won't be able to be covered by Medicaid or private insurance. And then I just wanted to mention as another thought, the way that the statute is written is that the eligibility, like the only criteria is around income. And I'm really excited that we're thinking about other considerations. I just want to flag that, it might be helpful to get the department's legal team's perspective on whether, what are the boundaries of what can be the rules for eligibility if the statute only says based on income. And, I'd love to have a conversation, if those were limited to those eligibility criteria, is this something that we talk about expanding in a cleanup version of the bill next year, or in a future legislative session?
Awesome, thank you. And then I think Dominic, you had some corrections or information to add.
Yeah, thank you, DezBaa. Not corrections. It's just really to kind of go with that is, Denali, you're right on track. Is we really are looking at this when, as far as for the equity fund, is really something that falls outside of when we can get insurers to pay and Medicaid to pay. And so it really is looking outside of that aspect. So it would first be trying, just like what happens when people go in for other medical appointments, it would be trying to get reimbursement through there. And then if that is not possible, then the equity fund would help fill that gap on it. And part of it is, yes, even though the language does just talk about the income requirements, it doesn't mean that that's the only potential requirement, because these other aspects such as transportation, care for other family members, we can still do it based upon that income aspect. It's just another portion of it, because it doesn't restrict how it shall be used. It really just says fund treatments of qualified patients who meet the income requirements. So it's just going to be a question of how we word that to ensure that these other aspects fit in within it, including that, that question of, when we have somebody who's in a rural or frontier area, how do we ensure that they're able to do that? Because again, if we're looking at a difference in income, for example, even from we have to figure out how to put it in there so that somebody who is closer into a potential provider, they may not actually qualify, whereas somebody who's 100 miles out in a rural community may, because there's no provider within that area. And so that's where we have to kind of figure some of those aspects out of how do we actually word that language correctly to make sure that we include that income portion while still meeting the needs in the other areas. So I'm glad you're already thinking about that, because that's some of what I have been struggling a little bit with, of how do we ensure that we can do this in these other ways. But we want to try to include as much as we can so that we can be treating not just the person, but really, that community, so to speak, the family and the community, not just the individual, because we know healing does not take place in a vacuum, and other people and supportive folks need to be included in this. Anyway, I hope that helps.
Thank you, Dominic. And so based on what has been discussed so far, and then for those who just kind of joined in, we're just trying to figure out what it looks like to use, or does someone else want to talk? Who is it? Based on just the criteria, what is the criteria that's involved in someone using and utilizing the equity fund? And what it sounds like from Dominic is that, and I think I want to put in kind of a little bit of an example where this might be the case, to include both what Denali was saying and Hannah in this kind of perspective. Is there someone else that wanted to, or did we just forget to lower our hands?
Hannah has
No, I
their
think
hand
they've
up.
just raised their hands again. So
Oh, okay. All
yeah,
right.
we can circle back to them whenever.
Well, so what I was thinking of possibly, just to kind of illustrate Dominic's point, is, and to kind of wrap everything together as a scenario, is, we have the poverty threshold at 15,960. So we had someone at 15,900, for instance, right? Then let's just say for all that. But I think to me, it sounds like it's a series of flowchart scenarios where, especially if the person, one has to happen with the other, right? So generally speaking, someone at that level, whatever the threshold is for Medicaid, Medicare, that kicks in. So if someone is on Medicaid, Medicare, then they definitely are eligible for X amount of treatment. And I think that would then also kind of kick in the copay. So that, I think, is just more an understanding of what happens when someone doesn't meet any of the criteria, and maybe someone can kind of clarify that a little more. So I guess the fund may or may not kick in for the gap if it's someone who already is at the poverty line. Maybe they have no insurance, would probably be one of the issues. But if they do have Medicaid, then they definitely would be covered. But what does maybe that copay look like? If that's already established, then that kind of sort of covers Hannah's point of investment, which I think is really important, and I did kind of raise that question before, because I do think that that really is a thing. You know, we do value something that we put our own sweat and equity, et cetera, into something, right? So I think that that's a valid point. However, only thing that I would say that may or may not happen is if, for instance, the Medicaid or Ready dictates that this treatment is covered. And then, of course, that goes into the cost of the treatment itself. And at this point, I think we don't know what that looks like. I know Denali put out the number of like $3,000. I actually don't know if someone has like a figure from either Oregon or Colorado, or just kind of a ballpark figure what that looks like. You know, maybe the cost of a treatment is actually $500. Maybe it actually really is $3,000. And that would depend, you know, per dose. So what is that? I guess market value. All this terminology that I myself am not really entirely familiar with. But I think all of that in consideration is what then would dictate, say, what Medicaid covers and how much of it, how much a copay would be for someone who is eligible for this treatment. But to the point of the family that's involved, yes, that is definitely an issue where, you know, the household member is like 2 or 3, right? So I'm a household member of 2. And I would need someone to take care of my child if I didn't have that available to me, right? So what would that look like? And how much is that based on like market value for someone to take care of that person? Is it going to be someone that is available in-house, or, you know, we give that person, let's say a treatment is anywhere from 4 to 6 hours, you know, at a time. So then that's $15 an hour, 4 times 6. You know, I'm not sure that this is, I think, are the things that we kind of have to look like. Are we going to, if the treatment itself is, say, $5 copay, but I need someone to take care of my kid while I'm going into this treatment and sitting in, then I'm adding an additional 4 to 6 hours, possibly 6. And is it even more, depending on, you know, how long it takes for the patient to actually go through the process? It might take 6 to 10 hours. So is there like a cutoff period? And I don't know. I mean, are these the kinds of things that we're having to look at, Dominic? And if so, like, that's where my brain is going. That's where it's wandering to when it comes to what's the cost of something. Is it fair market value? Is there like a cutoff? Is there, you know, travel? For instance, if, you know, if I was out in Abiquiu and the closest facilitator was in Santa Fe, that's like an hour and a half. And so what does that look like for transportation? Hopefully there would be someone in Espanola that I could potentially go to, which would be closer. But as we all know, if you're in Rio Arriba County and you get called into jury duty, it's always in Tierra Maria. And so it's like 2 hours, right? So what is that? Those kinds of things are interesting to look at when it comes to what's rural travel, transportation, and taking care of someone else. So I think from what it sounds like, that maybe the equity fund would be the best use, might be for those situations where you have a person who has a child or is taking care of someone else, and they really need to have that support surrounding them, because the cost of the treatment might already be taken care of with the Medicaid. Now that might change when it's someone who's not insured. And that's the part that I'm not sure of. And I think those are the things maybe that Dominic, I'm saying Dominic et al., the board, are looking for recommendations on how we use the equity fund. So if anybody else wanted to chime in.
All right. Let's see. I see Hannah's got her hand up again. So Hannah, let's see. Your mic is enabled. You can unmute when ready.
Thank you, DezBaa, and thank you, Dominic, for clarifying these equity fund details. As you both were speaking, some more ideas came through from a social work perspective. So in social work, when we begin to work with a client, we perform a biopsychosocial spiritual assessment. And what I'm wondering is maybe there could be an assessment process that's created specifically for this context, and maybe that looks similar to your idea, DezBaa, around making this equity fund for the rural marginalized population, since it's limited, since this is out of pocket. To me, that really distributes power to our rural communities, our native land communities, these marginalized populations, low income communities, in a way that shows how much we care and value diversity, equity, and inclusion. So I really like that idea, DezBaa. And I did some prompting about creating an assessment plan just for this with Gemini AI. As social workers, we're encouraged to work with AI in this kind of context. And what I can do, because it's a lot to read right now, is just maybe share that somewhere in the text or in the chat, just so there could be a written example of what AI responded to. And I gave a very specific prompt for this exact situation.
No,
this is-
I would suggest, yeah. Sorry, go ahead.
Yeah, Hannah, hi, this is Jorge at DOH. What you could do is we do, as we always do, put the medical psilocybin email address in there for public comments, and we'll share that again at the end, and we'll put it in the chat in just a bit. But what you can do is send that document up to 3 pages, and you can email that to us, and that will go into the minutes as part of public comment as well, and so that DezBaa has access to it as well.
Great, I will do that.
Okay, thank you.
And we had some other, was it, we had Hannah, Denali.
Hi.
Yep. Yeah,
hi
Denali, you
again.
can go ahead.
Yeah, just want to echo, I neglected to mention folks who are uninsured as in the overview of where the equity fund triggers, and that's a tremendous need in population. So thank you to the department and others who reminded everyone of that piece. I wanted to explore one of the things that I've been trying to imagine is like how do we make sure that we are reducing as much as possible the burden on patients and navigating the bureaucracy of this program, right? And so I'd love to see us create a system where we don't have an additional step that we're requesting of patients to apply to the Treatment Equity Fund. I think some of the barriers and conversations that we've had are, that the money has to stay really separate from the healthcare authority and Medicaid for federal legal reasons. So one model that I propose that I don't think is workable is, that if somebody is eligible for Medicaid, then they are deemed eligible without a separate application requirement for the equity fund. And I think that the trouble is that there can't be, we can't really involve healthcare authority. Maybe someone from the department can jump in and clarify that. But I think one potentially workable solution is that, and I think this exists already within some of our care models, especially in substance use and substance use treatment, is that the funding could go directly to the provider who is then committed based on the funding to providing treatment at no cost, you know, and it's up to their billing team, right? That like they bill Medicaid, and then whatever the balance would come from the equity fund. Again, just thinking about the well, I guess this would work too, right? Like if somebody came in and was uninsured, right, then their billing team would cover the whole cost. But that maybe if the funding goes directly to providers who, right, the system, DOH could set up a system for RFPs for, you know, and that's a way too to prioritize rural areas. And then, you know, the requirement is that they commit to providing treatment at no cost.
Okay.
All right. Oh, sorry, DezBaa, did you want to respond to that before we go to Kate?
We'll go to Kate first.
Okay, cool. All right. Kate Hawk, I've enabled your mic. You can talk when ready.
Yeah, hi, everybody. So just seems like now we're sketching out the factors. There's a lot of what ifs and unknowns, but you know, we at least want to identify all these things that are needed in some situations. And then we'll find out, well, what can be covered from this pot of money or this system and what isn't. And as I'm glad that everybody keeps mentioning all through this process, rural communities, because you know, they're often left out. I think one of the unknowns is, are people in the tribes really going to want this? And I know they just got a couple of members of the Pohoaki tribe to participate in the research, Larry Lehman's, you know, research there. But you know, as of now, it's not something people are clamoring for. But if people start finding it's available and getting results, then there could be a lot more interest. But right now, we just don't know. So I know we're just taking the steps that we can take. Being right in the middle of doing taxes right now, I will say, like, if there's plenty of money and we can cover babysitters and, you know, mileage and all that, great. Otherwise, you know, if we can cover some of the big pieces, like, you know, facilitators or some of the major pieces, you know, without having to do quite so much paperwork. Maybe that's the mood I'm in today. Uh, but you know, we'll see where it's going. And I think the other thing about making it accessible is models. Like, can there be models that really include a lot of effective group work that's not just more economical, but that's actually more effective, and then including more peer, you know, community people who have the skills that are needed, not necessarily, you know, a bunch of college and licensing that's not particularly relevant. So all of those things are going to go into, you know, what makes this accessible. And thank you. Love being part of this process.
Yeah, I'm going to start with you, Kate. And I think Dominic will correct me. I think that the equity fund is strictly for the patient side of it. But I wanted to clarify what you were meaning about the models in the community, just the last part of it that you were talking about, because I am interested in what you meant by that.
Yeah, I mean, these are interlocking pieces, and you're right. The fund doesn't tell us what models, like, is this for group work or is this for one-on-one, or, you know, it's just, okay, here's some money, and that's what we're talking about now, is how can this be used, you know, to help the most people. But that all, you know, what makes it affordable is it, you know, like there's some models of psychedelic therapy in even places like Oregon where it's just priced out of individuals' ability to pay. And it's great if we can get systems like Medicaid to cover, but also looking at how can we do the most good with all the resources we have. And that includes, you know, I think in a lot of times peer support and ongoing support systems can be more effective than having like in Australia, they were just like, they have a doctor sitting there along with two therapists through the session. Like, that those doctors are probably pretty bored. Maybe not bored, but not needed, right? So as we develop the systems where people, you know, and this comes around again to, well, when the tribes get involved, you know, ask people, what do you want? What do you see where this money could do some good? So right now, I'm glad we're just looking at all of this, and there's a lot of things that we'll find out more as it all develops.
Yeah, so I think I'm going to try to tackle what I hear you saying, and then I can go back to Denali's point and Hannah's point. I can remember. But Dominic can definitely correct me if I'm wrong. I think that the equity fund is strictly for the patient end of it. I'm not sure that it really has much to do with the facilitator training side of it. And I'm not sure where, you know, like what that looks like. So it sounds like there are like 3 different components to what you're saying. And they're great ideas. So what we're looking at, it sounds like that we're trying to figure out what to do with individuals seeking individual treatment, one-on-one treatment. And maybe that is a good point to put a pin in. If there is going to be a potential model for group therapies where you have, say, let's just put it out there, a family who wants to join in on this, you know, a father, you know, grandparents, like grandma, grandpa, and daughter, right? 3 of them. And it's a family dynamic. And they're all seeing the same facilitator, and they're all interested in going on to this treatment together. I can see that based in more traditional healing might be effective, and maybe that might be something to consider in the future. I'm not sure if that's where the equity fund would go, but I think it's a good kind of like subheading to what we could potentially look for in the future, or something that we could look into now as a way to tie into ancestral indigenous wisdom and healing, but also to provide support for the community. Because now, as they say, you're feeding more birds with 1 piece of bread. And maybe there might be something to that. I think that is very valid, if that's what you're saying.
Yeah, I'm actually just now reading the agenda and recognizing that the agenda is asking for specific recommendations for this fund. And, you know, I sort of backed up to the big picture. So, you know, having said that, we'll do the best we can to create the recommendations, because that's the job of this committee. And,
Yeah.
and it's what the agenda says. So sorry if I sidetracked anything.
Oh, no. I just why I was going to go ahead and go and honor that this is actually a really interesting point. So just kind of like putting a pin in it, that this might be something for the future, because I think it's very valid. You're right. And especially also with the tribes, we're still kind of waiting on the more formal invitation of talking to them. So we're going to get to that. But you're right, you know, it's always just been like, how do we address this? And so putting these things in place first and saying that this is what we came up with, and then also kind of, all right, this is what we came up while we were waiting for the more formal, while we were waiting for the sit down, while we were waiting for everybody to kind of congregate, essentially. Then we can kind of look at these things. Because if we were just kind of wait for everybody to show up to sit down to eat, then we'd never get around to eating. So we are looking at addressing the needs of the tribe, but I feel like, you know, it's up to New Mexico to figure out what we have, and then with input from the tribes, what they feel like, you know, they need support in. How do they need support? But it also goes to the same with like the rural communities. What do they need for support? To me, it's always education, providing, you know, as much information as we possibly can, so that people have the agency to help themselves as necessary. I think that agency idea kind of goes back to a little bit of what Denali was saying. I don't want to just sit there and put like my input in all these things, but a part of it is the agency of, yeah, I'm not familiar with all of the bureaucracy of navigating anything, even just to kind of figure out how to create a license or a business or to get an LLC. That's just a headache more than and no one's, they say they have all these videos to help, but they're not helpful. So I can understand the frustration of that someone really wants something. And I think that kind of goes back to Hannah's point of the reciprocity of what we really want to seek and how we're going to sacrifice something of ourselves to be able to get the thing that we know we need. I don't want to say that that's the bureaucracy, that that's the sacrifice to your sanity to kind of go through that. But I do believe that there's possibly a way that we can figure out, and a recommendation to the department. Is there a way to kind of facilitate that it's like a one step? I don't know. I'm not familiar with the bureaucracy. I have a headache on my own trying to create my own business. But I think that's a really valid point of, you know, is there a way to streamline this a little bit while also being able to help support our community? And as far as the psycho assessment process, that might also be helpful for a different committee that I'm neglecting to think about what the name of that is at this point. Yeah. So hopefully I kind of covered a little bit of what the things that were brought up. It looks like Dominic has his hand up.
Thank you, DezBaa. So a couple of things on this, and I just to sort of explain a little bit from the bureaucratic standpoint is, of course, we are trying to streamline things as much as we can, but also anytime funds are expended, we have to actually justify that expenditure. And so like in this case, and Denali, your point is very clear, as we don't want to have an application that's going to be onerous and very difficult for people to be able to apply for. So we have been looking for other potential markers, so to speak, that might work. The Medicaid, it looks like that's not going through, but we're still talking with HCA to sort of see if there's any way we can connect in with that. And that was a great idea Denali had brought up separately outside this committee, months and months ago. So we're still looking at that though. But there may be other potential markers, and we'll continue to look at that. For example, WIC. So if someone's enrolled in WIC, do they automatically at that point have it, or they already have that information? Historically, when we've had programs where income has been a factor as far as for funding to help with treatments or other aspects, it's usually been things like tax returns from the previous year. But there are sometimes other issues with regard to that. For example, some people who haven't filed their taxes, or they're late in filing their previous year's taxes, or just things like that that kind of come in that create an issue. What I would say though is let's not focus on that aspect right now, because we'll work through that portion. What we really need to figure out right now is what will be some of these standards. And just to kind of give an idea is if you look up the statistics, for example, of what is the current cost of living in New Mexico. And of course, this varies from different communities, whether it's in, Carlsbad or in Los Alamos, which Los Alamos has probably the highest cost of living in the state, or to Las Cruces or Albuquerque, Santa Fe. You're going to have a little bit of a difference, but the estimates really range about 46,000 to about 50,000 for a single individual for cost of living. And then that goes up, of course, when you have families and things like that. And the range actually varies quite a bit based upon what some of their needs are going to be, whether it be medical, things like travel, school costs, childcare, things like that. But when we think about that, one of the areas that keeps kind of coming up is if we look at that annual cost for a single individual, it really fits in with about 300% of the poverty level. As DezBaa was saying earlier, it's 15,000 and some change is what the poverty level is for a single individual. And by the way, I put a chart into the and a link in the chat earlier. And so if we're looking at that, one of the things that we could consider is if an individual is at 300% of the poverty level or less, that means they are just barely hitting that cost of living for the state. And so is that a good marker, a good level for us to look at and say, if someone is at that point, then we should figure out a way through the equity fund to pay for their treatment. And so I think what we really need to start moving forward are some a little bit firmer sort of guidelines and thoughts as far as what we can do there. And I would say start with income level first, and then we start adding some of the ideas about geography. So do we make adjustments on the income level based then on geography or distance from the potential treatment location, those sort of things, and start adding them in. And then I just want to hit one other point, and then of course turn it back on over to everyone else. And it was another point that Denali had brought up, and DezBaa, you talked a little bit about it as well. And this is a process portion. Anytime the state is actually going to be providing funds to someone through a state agency like Department of Health, there's really only 3 ways really to kind of do that. One, if we pay directly to the patient, we actually have to register that individual in our what's called the share system, which is the payment system and does all of our financials and all of that. We have to register them in there as a vendor. So that adds to the paperwork and the bureaucracy. So that becomes problematic. You have to get W-9 forms from people. It can be difficult to navigate. So that brings us, the next step would potentially be to pay the providers directly. So however many patients come in, and we can set it up similar to how it works for insurance and Medicaid, where basically that particular provider enters into our system as a vendor, and then however many patients they see in that week or month, whatever the frequency that they want to invoice the department, then the department reimburses them through that invoicing process. And then the third way is actually through a third party. The issue with regard to a third party that I just want to raise is that they always take a piece of that, of however much funding passes through them to pay out to, whether it be to patients or providers, they then actually take a portion of that. And it's been a while since I've actually done a program like that, but there was one I was involved with about 10 years ago. And at that time, that percentage was about 18%. So that, with the money we have, that means a fair amount of money goes towards administrative processing rather than the patients. So these are just considerations to think of. The main one we've been really looking at is as far as for the providers. And it is actually a part of what we did when we initially proposed the budget for the program. We actually included, one of the positions that we included was specifically to process those kinds of applications. So to assist patients with doing them as far as the application for the equity fund, and then paying providers, and so that the money goes that direction. That just seems to be the best use for the funds. But again, I could be wrong, and we definitely want to hear about it. Without having money going out of the fund into the processing, because that money then would come out of the operating budget for the program, and without creating additional burden for the patients through that first system I talked about, where they'd have to register as a vendor, W-9, all of that. And so I think instead of focusing right now on the bureaucracy side of it, because believe me, we want to reduce that as much as we can for everybody involved. And then what we would like to do is, if we could figure out what some of the guidelines would be, and and I would say if we want to start, we started talking about that 300% of poverty level, and then as people have thoughts and ideas, adjust from there. But just to use that as a starting point, and so I kind of would like to see. And Denali just asked a question in the chat. And so Denali, I can't guarantee it will be there, but if I have any influence in doing it, yes, that would be a position that I would be requesting in that FY28 budget. But as you know, I can't guarantee that because it depends. Well, a lot of it will depend on the election. So we'll see what happens there. Anyway, thank you, everybody.
I think we had Hannah wanted to say something.
Yeah, you can go ahead. Your mic is enabled.
Thank you, Dominic. I agree with you about leaning towards that provider reimbursement. Yeah, that just intuitively felt easeful when you said that. And then also, I wanted to expand upon DezBaa's, what she spoke to, yeah, around that reciprocity and education. So again, this does not directly apply to these ideas of, money funds at the moment. I just want to invite in this deeper level of cultural consideration, and expand upon that very real topic of education. So as particularly on tribal lands, the populations there have what we call historical trauma recognition, or historical trauma, like from a social work perspective, where the historical trauma that's rooted within their belief systems has created a deep-seated distrust of the medical systems, in addition to historically suppressing their traditional healing, which creates a distortion of needs through systemic oppression. And so I'm almost wondering if there's a need within the medical psilocybin program for building relationship, because what happens in social work is with those deep-seated traumas that are systemic, then the approach for the social worker becomes building relationship instead of having like an assessment piece of paper, because we're addressing this kind of trauma-informed approach. And again, for oppressed cultures to step up and be like, I want to participate in this program, there's going to be education and like a slow unwinding and re-bridging of us to these systems, of us in the medical psilocybin program. Yeah, I feel complete in that. Thank you.
Thank you. To kind of go back to a little bit what Dominic was addressing as far as like how we're going to be able to utilize the funds. And this is, of course, just my own opinion on things. But this is just an example. So the national average cost of living, according to the wonderful internet, is $78,535. I don't know anybody who makes that much money. I mean, I do, but I also don't. That's the cost of living nationally. Here in Santa Fe, it is $87,959. Again, I don't know anyone making that amount of money. According to, again, wonderful internet, Albuquerque is $75,393.6. Espanola, somehow, I have no idea how this is even possible, $71,466.85. That's outrageous. My ex-husband was trying to get a job in Rio Doso for $40,000 with a $2,000 bonus sign-on. So these numbers are just insane. And the national poverty average is $15,000. I can't remember the name of the person. I know this is a little bit off track, but it's just like how we're supposed to be able to help fund these things is that the actual cost of living is the average poverty line around is like closer to like $100,000. Maybe that's an exaggeration, but it's way above $15,000. I don't know who came up with these numbers or what kind of magic math they're using that $15,000 is the poverty line. But these are the numbers that we have to work with, and that's just as an example for why being able to help provide this medicine in the way that we're doing it And for the people who are seeking this particular route, just to kind of emphasize that, because there is the underground, but this is also for the people who are seeking it in this particular way. And this is how New Mexico State is providing its way to help its citizens who want to go this route, who want to, and to be able to provide it for as many people as possible. And that does definitely include our native populations. And to that point, what Hannah was bringing up, yes, as a Dene person, one of the things that we do understand is this idea of essentially making us wrong for the medicine that we've already been using for hundreds of years. And so in this particular way, the state of New Mexico, we're trying to move forward as best we can for, say, the rest of us. Law-abiding citizens who have for such a long period of time been told that this is wrong. And so we are having to battle the stigma not only from decades of the government telling us that it's wrong, but this is the time and the opportunity that is happening within the state, one of the first 3 states to do so, to bridge that gap and to unwind the effects of what was imposed on its people prior to 1912. So a lot of this is very historical. And even what we're doing right now as a government and within the state of New Mexico and the DOH is very historical in a lot of ways. It does have a financial responsibility. And that's what we're trying to do right now. What is the responsible financial way that we are taking care of the citizens who choose this route, who choose to utilize this opportunity that New Mexico is providing in its own framework to unwind that and to move closer to what I would consider more equal footing across the board. It's going to take a lot of us to move past the fear from every side, both native, non-native, people moving in everywhere, to really fight to figure out what we need to do. But we have to do it in the specific way. And right now, the job is, what are we going to do with the money that we have? How is it going to be taken care of? How do we provide the support systems? And what does that look like? So, and it has to be very, very specific. That's the call. That is the issue at hand. That is the right thing to do. I think Denali had her hand up.
Yeah, thank you. Thank you, DezBaa, for that. And for sharing so much of your own experience as well. I'm wondering, as you were going through like the cost of living, I just wonder if it might be a helpful tool for the committee to make this decision, to have kind of aggregated how, like, what different programs in New Mexico use as metrics of eligibility. And I'm wondering too, I think this is a question for the department, whether that, whether there's resources within the state, whether that's like the DFA or Legislative Council Service representative for the department, if there's an opportunity to ask for collaboration to create some kind of aggregated tool for the subcommittee to like have a more global understanding, and by global I mean within our own state, but like how in across programs in the state are we creating eligibility based on need. And I just feel like there's some learning I could do about how other programs operate, and it would be helpful to inform the decisions that we have to make.
Yeah, I think that that's a good idea as far as, I mean, and I hope someone can verify this differently, because there's the eligibility for the Be Well, which is like a completely different thing, but it also triggers the thing for the Medicaid, and then it decides whether or not you want to, and then you have to deal with Medicaid, and you also have to deal with Be Well, and that is so much brain power. It's, yeah, and I feel like trying to just find something that has worked well enough to figure that out would be helpful in terms of this. All right, so I think it was Dominic who his hand shot up first.
Yeah,
Or-
thank you, DezBaa. And Denali, that's exactly what I was talking about when I was saying that we're looking for those other markers. So we don't have to necessarily duplicate what's happening. What I hear you saying, though, is if we could sort of create some sort of a chart or table or even summary of some of those points really for this committee. And we can definitely do that as we move forward. But part of it is we have to figure out what some of those potential markers might be. And that'll help from a bureaucratic sort of standpoint for being able to ensure we're processing things forward. But I don't think that's going to necessarily fit in all cases because we are going to have other situations where, as like Hannah was saying, is we need to be looking at some areas with regard to, the different regional differences. But in any case, what I really, because we just have about 15 minutes left, I would really ask if we could sort of get a starting point, and kind of start moving from there, talking as far as whether it be income level or otherwise. And then as we get that other information, we of course can move that. So not adopting, here's what it will be, but start talking about the specifics, because we can continue to talk about the other aspects of it for months, quite honestly. But if we don't start laying down at least some marker points, we're not ever going to move forward, because we can talk about the equity issues and the lack of equity that we have in the state for years and never stop.
And to that point, Dominic, it sounds like what we're needing to do is just decide to establish like what is, just putting something baseline down, that it's based on the poverty levels, which, I have no problem with saying that that's like the starting point. It's like, yes, we're going to base it on that. I think the only thing I would have is that just the standard for all the low income programs in New Mexico? I mean, is that across the board for WIC and SNAP? And what are the criteria for WeWell and Medicaid? Are they all utilizing the same one? And whether or not their percentage is above or below, because like I said, the cost of living here, even if you say the $15,000, that cuts off, to me, that what I'm trying to say is like, that cuts off people like me. Let's just say it, for me, for example, that cuts off me. I'm not at the poverty level, but I'm also not making a lot of money. So where does that put me? A mother of one, who definitely is still struggling to pay rent, right? Who could definitely not afford to have a treatment of $100 or copay, no matter if that's what the guidelines say, that I'm supposed to somehow pay $100. I can tell you right now, I can't. So I think that that's maybe what we're trying to look at, if I'm not mistaken.
Yeah, and what I was saying on that, DezBaa, is if somebody is at, for example, 300% of the poverty level or less, then the fund would cover their treatment costs. Now, if it covers the travel and all of that, that may be different. So, for example, in your situation with a household of two, that would put it at about $64,000 a year. So if you were making less than 64,000, then the treatment would be covered. But that's just a starting point. We can also look at, and I had mentioned this, I think, in a few meetings back, is say then, for example, someone's at 350% poverty level. Maybe then the guidance is that we pay for up to, say 75% of the treatment cost. And then at 400%, and I think those are the things that we need to start thinking about, is how much will that do? always keeping in mind, it depends on how many people end up applying for this out of that total pocket of fund. And that's why I've been saying we should look at it regarding the poverty levels in the state, not in the nation, because the nation also would be much bigger. Oh, and Hannah just put something up. I missed that, Hannah. So yes, looking at the poverty levels between that, and we could say it's going to be based even on the more local, on the county level, and that we could see about trying to come up with what that chart is. I'm not sure who might have it. I do know I've seen it before. And so looking at that aspect where we say within the county level, here's what the poverty levels are for, say, and I'll just say it because I was just talking about Roswell the other day, but Chavez County. And so we say, what is the poverty level in Chavez County? And then base it upon that. So varying it with regard to those local areas.
No, I think that's a really smart idea, because that was a reason why I didn't realize why, but that was the reason why I was bringing up Espanola. That's where my hometown is. I'm living in Santa Fe. The reason why my parents couldn't live in Los Alamos is because it's too expensive. And that's why everyone ends up in Espanola. But if you're going by county, then that definitely makes a lot more sense, because if you average everything out in New Mexico, I mean, Santa Fe and Los Alamos shoot everything up, and it's impossible. I think that would be a good place to start. Is anybody else? Greg?
All right. Whoops. Okay, let me get your mic here, Greg. All right, you should be able to unmute.
Hey, I've been kind of in and out today. And is my mic working?
Yes.
Yep.
Okay. I've been trying to find a way. So I don't think I've heard this specifically said. So I think it might be interesting and bold and complicated to earmark a chunk of that money, say like half, and make it reparation style spending. So develop education and outreach to specific ethnic or other group communities, and say, look, we are giving you this money. This is how you can use it, and like spend that money in a very specific distributive manner. People would have to apply and fit into the category of acceptance to receive the therapy or whatever. But it's like, take that first chunk of it and be like, here is money that we are just putting back into this community. It's like our native populations, our first peoples in this state, are not traditionally using psilocybin. This would be a new modality, but like, let's take this modality that we are creating and say, hey, if this is useful to you, we want you to receive this. Just brainstorming. But I would love to see the word reparations be used.
And then I see Hannah, it looks like you're in agreement with what Greg was saying. Denali, did you want to say something? Oh, we're just wrapping up here really quickly, so kind of. Denali?
Yeah, grateful for that contribution. And circling back to the comment that I made earlier about the statute and the limits of the statute, I think that's where the rub would be, right? Is not that income is the only factor, but it has to be an eligibility criteria. And maybe there's a way within what you're imagining, Greg, that works. But like at the starting point of the inquiry, the way that I read what the department is required to do in terms of creating eligibility, yes, we can consider other factors, but like the principal eligibility factor is tied to income and not some other, right, like historical oppression or other things that are really relevant to the way that we decide to share resources in this state. But that's my only contribution.
Okay, thank you. We just have a couple minutes. I wanted to say thank you all for everyone and your contributions, just to kind of put a little pin on that. Yeah, I think that's a great idea, Greg, just to kind of put it out there into the future, because these things, what we say can possibly cast spells into the future. I definitely believe that. You know, I think for the future, it might be a good strategy for people to kind of understand that that might be what it's worth. Reparations are definitely important, and I think that that's a good place. And then also, to Denali's point, we do have to base what we do with the money on the limitations and the criteria for which it was provided. But I think it definitely is a great idea. I know other places have done the same thing. I can't remember if it was Oregon or maybe it was Colorado that, or, you know, allowed the tribes to be able to fund what they felt was necessary. But again, you know, we're going to wait to see what, have those conversations with the governors when we can make those appointments and those invitations happen. That would be great. Thank you for your time. I think we're probably going to try to come up with a meeting. Is it okay if we don't come up with one for right now? Because I know we are meeting, I don't even know when we're meeting next. I think it's in May for the board meeting. But what we're going to do is we're going to try to get an in-person meeting set up. I think that's going to be my next, but I have to coordinate with the coordinator for that. And in the meantime, definitely take the email, medicalpsilocybin@doh.nm.gov, to talk a little bit about what you had a comment on. Use the subject line as a way to kind of inform the committee what it's about, the date of the committee meeting, the name of the committee meeting. Again, thank you for your time. I hope you have a great rest of your day. And if there's any closing remarks from Dominic and the admins, go for it.
Yeah, thank you, DezBaa. I think it's fine to hold off a little bit on a meeting until we get that other one set up with that. And just as a note, I had put it in the chat in the very beginning, but I know some people joined a little later. So just in case they haven't seen it, is we did have the rules on the propagation and laboratories did publish today. So if you've been involved in some of those committees, and I did put that in earlier. But the other aspect that I just wanted to put in, and we'll put these into the chat so that people will have them, is don't forget to go to the website to see as far as upcoming meetings. And so we've got that in the chat right now. And like I said, in just a moment, I'll get the link about it's to a website for where you can see the public notice and where you can see the proposed rules. And so I've just got that in the chat now as well. So look forward to everything else happening. We've got a lot still happening in the next few months, and this is great conversation and some great ideas. And now we just need to start moving things forward. So thank you, everyone. Hope you all have a great day.